What is the difference between a jeweler and a cell biologist? A jeweler and a cell biologist. One sells watches and one watches cells. I kind of like that one. What do you get when you cross an elephant with a fish? An elephant with a fish. Reproductively, don't ask me how that happens, but swimming trunks. Why was Tigger looking in the toilet? This one's a little less academic, but he was looking for poo. Oh, come on. I thought that one was good. Okay. That one makes me laugh every time. All right. Yes, maybe I'm stuck in seventh grade boy. Okay. So we're talking about renal diseases today. First up, let me ask this question. The area of the kidneys that contain the glomeruli are what? What's the area that contains the glomeruli? Any takers? The cortex. All right. If we look at the anatomy of the kidney, so here's our cortex here, our capsule is on the outside, the medulla is here in sort of these triangular pieces. We're going to look today at glomerular disorders. We're going to look at renal failure, and then we're going to look at different types of infections. Now, remember that the glomerulus and its surrounding Bowman's capsule makes up the renal corpuscle. Do you all remember that? And this is the basic filtration unit of the kidney, is the glomerulus. So the glomerulus was kind of that tuft of capillaries, that conglomeration of capillaries that looks kind of like unorganized, like a ball. And then there was a space around it. And you have this as the basic filtration unit of the kidney. Now, the nephron from the Greek nephros is translated directly as kidney. So nephron actually means kidney in Greek. And that's the basic structural and functional unit of the kidney. So the filtration unit is the glomerulus, and the functional unit is the nephron. All right, so let's take a peek at some of the organization. We already kind of talked about the rena medulla. We talked about the renal cortex, where the glomeruli are located. We've got our capsule. You can see that all of these renal cortexes or cortexis collect the fluid and dump it into the ureter that goes to the kidney. I'm sorry, goes to the bladder. From the bladder, both ureters empty into the bladder, and then you have a urethra that comes out from the bladder to expel urine. And you can appreciate that we've got a renal artery and vein pair. This renal artery comes right off the aorta, so that the kidneys get about a third of blood flow on every heartbeat. Every time the heart pumps, the kidney's getting the blood flow. So this is a giant filter. There's two of them on either side, right? One usually sits a little bit higher in the peritoneal cavity, and the other they're posteriorly positioned. They're below the rib cage, so they're not really super well protected. A filtration organ that's off of renal blood flow. What's a filtration organ that's off of venous blood flow? What's that? The liver. Okay? So you have a filter on both sides, which is kind of interesting. Remember, the liver is the portal system, the venous circulation that runs through the liver. Okay, some terms that we need to define just before we kind of get going here. Urea. Urea is a result of catabolic activity or catabolism of amino acids, making uric acid. Catabolism of nucleic acids as well, which creates creatine. So that's urea. That's a breakdown product of amino acid and nucleic acid breakdown. Azotemia, elevation of blood urea nitrogen, or what we abbreviate as BUN, B-U-N. You can see it at the bottom of the slide there. So this BUN or BUN, blood urea nitrogen, is a measure of the amount of nitrogen in the urea, which is a waste product, another waste product of protein metabolism that's happening in the blood. So if a patient is breaking down a lot of protein, you'll see a lot of urea or a high BUN content in their urine. Uremia, this loosely describes illnesses that surround kidney failure. Uremia. Proteinuria, what do you think this is? Proteinuria. Presence of protein in the urine. Typically not a good thing. Glycosuria, not on the list, but what is glycosuria? Presence of glucose in the urine. You could write that one down and underneath oliguria. Hematuria on the list here. Presence of what in the urine? Red blood cells. Yep. May not just be blood in the urine, it just could be trace amounts of red blood cells. It may not look bloody. If it looks bloody, then yes, it's hematuria. I recently discovered, just because I was visiting my niece, and she has a lot of like special extra needs. And my brother and his wife were worried about, she was having some blood in her urine. I guess it's actually somewhat common in pediatric patients, more common than in adults. No infection, kind of resolved itself. So in pediatric cases, just because there's blood in the urine, it doesn't necessarily mean that, bad things are happening, but you track it. If there's no pain, if there's pain and discomfort, there might be a UTI. We'll talk about UTIs at the end. Pyuria. Presence of what in the urine? Not red blood cells, but white blood cells. Typically a sign of some infection, some systemic infection. And then oliguria is, anybody know what that term is? Oliguria? That's a decrease in urine production. So your GFR has dropped, your glomerular filtration rate. Do you guys remember that term, GFR? GFR is directly proportional to how much urine you make, how much you filter through the glomerulus. Okay, so let's move on and talk about some of these glomerular diseases. So these glomerular diseases, some examples are glomerulonephritis. That's a complicated term from what it looks like, but what do you think it translates to? Glomerulonephritis. It's inflammation at the level of the glomerulus. Okay, glomerulonephritis. Diabetic nephropathy and nephrosclerosis. So we'll kind of walk through each one of these. So these all impact glomerular function. So you have an altered glomerular filtration rate, or GFR. And chronic glomerulonephritis is a aggressive inflammatory disease, chronic version of this, and you should understand what that terminology means now this late in the semester. But that's actually the most common cause of chronic kidney disease, is chronic glomerulonephritis, where the glomerulus is actually inflamed. We'll talk about like pathogenesis here in a minute of how that all takes place. I mean, many of these things are immunological, right? A type 2 or a type 3 hypersensitivity that we've learned about. So there's an immunological component. There's an antibody-antigen reaction that takes place. You could have a symptom known as Goodpasture's syndrome. So this is pretty rare, but it's life-threatening. It's an autoimmune disorder, Goodpasture's syndrome, where the body attacks the collagen in the basement membrane and usually hits the kidneys as well as the lungs. Similar collagen, Goodpasture's syndrome. So these are all immunological origins that we're talking about here. Now, at the end of the lecture, we'll start talking about like bacterial infections that can cause kidney disease. But for the most part, like kidney failure is going to be either a glomerulonephritis, a diabetic nephropathy. So remember in the diabetes, like in the endocrine lecture, when we were talking about the problem with diabetes, what happens to the vasculature in diabetic patients that are unmanaged over a long period of time? What do you recall? What happens to the blood vessels? You have unmanaged high sugar, high glucose in the bloodstream. Is that good for the blood vessel? It's bad for the blood vessels. It causes lesions to accumulate on the lining, the endothelial lining, right? It prevents blood flow distally. So remember, they get that parathesis feeling. They get that a neuropathy, not nephropathy, neuropathy, meaning the nerves die and they have that pinprick feeling. Do you remember that? So this is talking about the nephropathy, not neuropathy. All of these occur. Vascular disease in diabetics, neuropathy or death of the neurons. That's why they lose distal feeling in the extremities and they're prone to diabetic foot ulcers. Well, the vasculature in the kidney also has those lesions. And so the nephron becomes compromised. You get an accumulation of extracellular matrix in the glomerular basement membrane. Accumulation of extracellular matrix, or ECM, in the glomerular basement membrane. If the basement membrane thickens in the nephron or the glomerulus, what does that do to the ability for blood to be filtered? Helps it or compromises it? Compromises it, right? A thicker basement membrane means there's a bigger difference for solutes to actually have to filter across. So you don't want a thick basement membrane in the nephron. And then nephrosclerosis, this is where you get excessive disease of the arterioles in the kidneys and they get damaged and they scar. Get scarring of the arterioles, nephrosclerosis. So let's talk first about glomerulonephritis, abbreviated GN. And this is a sort of a diagram that you're looking at here at the level of the basement membrane of a glomerulus. So this little box, you see this rectangular box, that's what's being shown in these three pictures. So we're blowing these up so that you can see them in higher magnification. We've got these two, which are called circulating, and these two, this one's called circulating, and these two that are in situ. So the far left one is circulating, and the middle and the far right are in situ, or in location. So let's explain what's going on here. We've got inflammation of the glomerulus happening. We've got an immunological response. You're developing an antibody-antigen reaction. So if it's an antibody-antigen reaction that occurs somewhere in the body, and then that complex circulates around and gets trapped in circulating, is that a type, what type of hypersensitivity is that? Type 3, very good. Type 3 hypersensitivity. So let me say it again. You have an antibody-antigen complex that forms because an antibody forms to some antigen in the body. It circulates in the bloodstream. This is a filter. It gets trapped here. And do you see how it's trapped here? It's trapped here. It's trapped here. And it's trapped here. You see those like local areas of concentration of entrapment of a antibody-antigen complex? That's a type 3 hypersensitivity, if you remember back to our immunology. So that's the circulating type. If it's an in location or an in situ, then there is an anti-glomerular basement membrane antibody that's made. And if it's an anti-glomerular basement membrane, it's not as punctate. It's not like stuff gets trapped. It reacts to the entire surface. And so it's more uniformly bound to the basement membrane. And that, if the antibody is to the actual tissue, what type of hypersensitivity is in situ? That's a type 2. Nicely done. That really makes me happy. You don't know how happy that makes me, because that means that you're actually remembering this stuff and it's starting to click. Okay, so glomerulonephritis. Is it an antigen antibody complex that forms somewhere in the body and then it gets trapped in the filter? Or is it against the kidney glomerular basement membrane itself? You need to understand if it's a type 3 or a type 2 hypersensitivity, and that's what we were just talking about. So what does this look like as things, play out? Well, you get these complexes which activate complement. Complement's complementary to what activity? It complements what? Inflammation. Yeah. You release complement to aid an inflammatory response. Remember, this is glomerulonephritis. This is inflammation of the glomerulus. So you recruit neutrophils. There are first responders, right back to the very beginning of the semester. You bring monocytes out of the circulation. They turn into tissue macrophages, and now they're activated. You bring in platelets. You degranulate, so the macrophages dump their contents, their signaling molecules, and you start depositing all sorts of scar or fibrin and collagen as it scars over or creates a fibrotic response. So in this picture, I have two different stains. The stain on the left, these are fluorescent antibodies. The stain on the left is more punctate. You see how it's not continuous? It's not like it's a green marker that's just been drawn. It's like kind of pointillism, right? Like it's like dots. And so there's big gaps of black between the green stain. Can you kind of appreciate that? The one on the right, you see how this is more linear. It's almost like a marker was tracing the glomerular basement membrane. So with those two observations, which one do you think is a type 3 hypersensitivity? The left, or the green, or the right, the yellow? Type 3 hypersensitivity. Remember, type 3 hypersensitivity is which one? Antigen antibody that binds together in the bloodstream, and then it floats through and it gets trapped in the filter in the kidney. Which one do you think that is? Yeah, I see people pointing like this, right? Yeah, the left side. The green side is more punctate. Stuff gets trapped in certain spots. So it's considered what we refer to as a granular characteristic of circulating type 3 hypersensitivity. And this would clue you in, if you saw this image, that, oh, this is a type 3 hypersensitivity. If you saw the histology on the right from a biopsy, this is what we refer to as linear characteristic. Whereas the antibody is reacting to the glomerular basement membrane itself. It's not a complex that's floating through the blood like a type 3. It's a type 2 hypersensitivity on the right, known as linear, and it's staining it more in a continuous pattern. Can you appreciate the difference between the two, just observationally? So that's diagnostically, that's how you would discriminate between the two. All right, we're going to get into different types of glomerulonephritis. So the first one is rapidly progressive glomerulonephritis, RPGN. So as the name would suggest, it occurs very quickly, very, very rapidly. Its etiology isn't well understood of why it comes on. You can see a normal glomerulus on the left, and hopefully what you can appreciate is, do you see the Bowman's capsule, the white space around the tuft of vasculature? So this is a glomerulus, and here's the white space. Over here, do you see this glomerulus? There's no white space. It's full of purple inflammatory cells. Do you see the difference? This comes on very quickly. Within weeks to months, the patient has basically glomerulonephritis, a loss of function. They're not making much urine, oliguria. They might have protein in the urine, proteinuria. They might have sugar, glucosuria. They may have white blood cells or red blood cells, all the things that we just talked about. Many of these patients, this happens due to some post-infection that the body was trying to clear. It could happen with patients that suffer from lupus, systemic lupus, or patients that have the Goodpasture syndrome, which is an autoantibody to collagen 4. I don't think I mentioned that previously. And it's not a great outcome with respect to what can be done. Now, root cause, if it's a bacterial infection, then they can treat with antibiotics. If it's some other autoimmune disorder that we're talking about, they may put immune suppressant medications on board for the patient to try to limit the progression of the glomerulonephritis. Okay, the next type is called acute diffuse glomerulonephritis. Acute diffuse. The most common time that this occurs is post-strep infection, a streptococcal pneumonia infection. These are usually younger patients because they have a higher predisposition to developing strep infections. Remember we talked about, like, when was the last time you had strep throat, right? And maybe some of you had a lot of strep throat when you were a kid, like twice a semester, three times before Christmas, or you were always, wrestling with antibiotics during Christmas time because you had strep throat. And now you're like, I can't remember the last time I had it. So post-strep, usually between the ages of 6 and 10, although it can happen anytime in any age, but that's sort of the biggest onset of patients. Usually it's about 1 to 3 weeks after an infection. The antigen gets trapped in the glomerular basement membrane, right? If you remember to the type 2 hypersensitivity, true to that immune lecture, we had the glomerulus. We talked mostly about the heart when we talked about that lecture, and we had strep, from a rheumatoid fever or scarlet fever. Do you remember that lecture? So that was a strep antigen that was trapped in the heart tissue. Here it's being trapped in the glomerulus. Okay, similar result. It kind of attacks that tissue. If it's a strep infection, you can treat with antibiotics. It's pretty straightforward now. Chronic glomerulonephritis. This is the most dangerous, I would say, because if it's chronic, it means it's going on for a long period of time. The rapid progressing and the acute, usually there's some incident, an onset, and if you can figure out what it is, you can treat. Here, because it's chronic, that means nothing's been working. This inflammatory disease of the glomerulus has been going on for a long period of time. So it's often an outcome of other types of acute glomerular diseases. And what happens is you get a lot of scarring that takes place. So this is a Masson's trichrome stain, and in the blue is, this is a sort of a, I wouldn't say a normal, but this is still an alive and functioning glomerulus. You see this one here in the middle with the white capsule, the white Bowman's capsule. But you see these are dormant. Now they're all full of collagen. They've scarred over. So these 1, 2, 3, 4, 5, 6, these 6 blue spheres in this picture with the one normal one in the middle, or functioning one. I would say normal, but probably low functioning. So this functioning glomerulus gets scarred over because the inflammatory insult is so great for a long period of time, and you replace functioning glomerulus with scar tissue, just like what happens in a wound in the skin, just like what happens with cardiac tissue. We'll talk about that, the last week that we're together. And it's just like what happens with the brain, with stroke. So the outer surface upon gross palpation, this would have a cobblestone type of a feel to it, or like a rough surface. It wouldn't be smooth to touch. Okay, this is obviously at explant. okay, not in the peritoneal cavity. Which one of these are normally found in urine? Water, ions like potassium, sodium, bicarbonate, creatine, urea, some protein, let's put it that way. Not large amounts of protein, but some protein. Well, let's put it this way. What about moderate to large amounts of protein? Let me put it that way. So everything should be there but protein. If you have some protein in the urine, it's probably not a huge deal. They'll probably retest you. Get another urine test. Trace amounts. But if it's moderately high or if it's high, something's going on. Okay. What are some of the clinical manifestations that you would anticipate with glomerulonephritis? Like any of the ones that we just talked about, any of the three? Rapid, progressing, acute, or chronic? What are some thoughts? What do you guys have? Things that you might expect to see happening in these patients. They're on their way to kidney failure. Okay, so swelling around the kidney or in the peritoneal cavity, maybe retroperitoneal cavity, like towards the posterior aspect. Tender to touch. Okay, swelling. If it's swelling there, do you think if you're not filtering fluid well enough, do you think you would have a lot of fluid collection in the body or edema? Yeah. Okay, little edema, a lot of fluid retention. Do you think you'd have high levels of urine output, normal levels of urine output, or low levels of urine output? Low, what's that term? Oliguria. What are some things that maybe you might find in the urine? An indication that it's not going well. Moderate to high levels of protein, agreed, in the urine. What else? Maybe red and white blood cells. Anything else? Maybe some sugar and some glucose in the urine. Okay. So a urine test will tell you how the kidneys are functioning pretty easily. Kind of one of the go-to. There's a lot of information you can learn just from a straight urine test. Okay, nephrosclerosis. So this is scarring of the tubules, of the nephron tubules. So this is often seen in diabetics, like we mentioned earlier, seen in patients that are hypertensive, because if they're hypertensive, meaning they have high blood pressure, if there's high blood pressure, that's measured in what circulatory tree? Arterial or venous? Arterial. And where does the kidneys, where do they get their blood from? The arterial side. So if the aortic pressure, if the pressure in the aorta is high blood pressure, hypertensive, how does that translate to pressure in the kidney? Is the kidney seeing high blood pressure? Absolutely, because it's getting that blood right off of the aorta, right? So the arch, the aortic arch comes here. The brain and the heart itself get the first pump of blood, and then you have a couple of intervertebrals as it comes down, and then the main two branches off of the aorta are the renal arteries. So if you're hypertensive or high blood pressure in the aorta, then you're going to have a lot of hypertension in the kidney as well. So These vessels, do you see the thickening of the wall here? Though that's hyaline arterial sclerosis. That's a hyaline remodeling. So like a hyaline remodeling of tissue that's not supposed to be there. Do you see how narrowed that lumen is? That's a cross-sectional view. It should be what, I mean, this one's a little more open. This one's pretty aggressive. You can see this one looks pretty normal right here, but these two have this thickening of the medial aspect. So that's scarring that's taking place as a result of the high pressure. So what are some of the clinical symptoms here? Well, they have proteinuria, so they have protein in their urine. Oftentimes, they might be asymptomatic. They don't even know it. They have a general and focal ischemia of the kidneys. And they also have low serum protein, meaning on a blood draw, like there's protein in the urine, but there's low protein in the serum because they're excreting a lot of the protein that should be staying in the bloodstream. And if you recall to the liver lecture, the importance of that we talk about in the liver lecture is the liver makes albumin and proteins. It manufactures those. And those circulate in the bloodstream. And that creates a colloid osmotic pressure for fluid to want to go to where solutes are. So fluid is moving to where it's high protein. It should be high protein in the venal circulation. And that's what brings fluid back from the extracellular matrix and reabsorbs the fluid from the extremities back into the venous circulation. So if you have low protein in the serum, you're going to get a lot of edema in the tissue. You follow that? And so the liver lecture, we talk about that because they kind of go hand in hand. Both of these go hand in hand. The kidney and the liver, in this regard, work very close. They're both filters. One's manufacturing protein, the other one's trying to preserve it, right? Okay, let's talk about failure as things progress. So in which structure does reabsorption first occur? It's kind of a review question. Glomerulus, proximal convoluted tubule, the nephron loop, the distal convoluted tubule, or the collecting duct? Which one first? Proximal convoluted tubule. Okay, so if you think about the architecture and what we're trying to accomplish, let's talk about when it goes bad, when it goes south. So acute renal failure, we've got a severe decline in function with a decrease in urine production. And there's really sort of three ways that this can happen. You get a severe reduction in glomerular filtration. And there's either 1, 2, 3 different mechanisms that this can happen. So number one is it could happen before the blood ever makes it to the kidney. Pre-renal. So pre-renal, there's a immediate drop in blood pressure. So that the patient's in shock. This is usually during trauma, when large amounts of blood is lost from the patient. Okay, so any first responders or paramedics in the room, EMTs, first thing you do is you stabilize the patient, right? You're checking respiration, you're checking if the heart's running. Okay, you don't move them, you stabilize, and then you IV access and get a line in, right, to get fluids. Well, once the patient is stabilized, if they've lost large amounts of blood, the next thing that you're worried about between the brain and the heart are the kidneys. The third thing that you're worried about is kidney function. So pre-renal from shock or large amounts of blood volume being lost, that's when the kidney can basically die. Okay, or parenchymal. Parenchymal is a word that means like the functional tissue of that organ, the parenchymal tissue. We talked about that word in brain. We'll talk about it in heart. We'll talk about it in respiratory. Talk about it in liver. So parenchymal is just a word that means the functional tissue of that organ. So the things like the glomerulus, the health of the glomerulus, or if it has any glomerulonephritis, this would be a cause of renal failure if those glomeruli continue to deteriorate. And then third is post-renal. So post-renal, so you can see here's number one is the renal artery. Number two is the tissue itself. Number three is anything of the urethra, the bladder, or the ureter. So post-renal, an obstruction, an infection, like a urinary tract infection. So in the extreme cases, a UTI untreated, which would be very uncomfortable, but it actually could lead to kidney failure. And that's why it's taken very, very seriously. And they're actually pretty common, right? But it's very easy to treat because it's usually bacteria, so you just put the patient on the antibiotics. Okay. So let's walk through these. So number one, we'll look at we're going to walk through the I talked about this. We already talked about parenchymal. We're going to walk through the post-renal. So etiological agents. So an infection, like a urinary tract infection. We'll talk specifically about pyelonephritis here in a couple of slides, but this is known as basically an ascending urinary tract infection, pyelonephritis. Pylum is a word that refers to the pelvis of the kidney. So pyelonephritis is the pelvis, the nephritis, the nephron part is Greek for kidney. So this is the pelvis of the kidney. So we'll talk about that. So if the urinary tract infection is coming from the outside, then we would refer to this as pyelonephritis. And there are some patients that are a little bit more predisposed to this because of some sort of regurgitation that takes place after urination. We'll talk about that. Acute tubular necrosis. Now, this one is probably the most common cause of renal failure is acute tubular necrosis. Well, if you recall in 202 when you looked at kidney anatomy as well as physiology, is the nephron gets the oxygen at the very end. Now the kidney itself gets the blood flow right off of the aorta, but the nephron's the last structure that actually gets perfused. So it's the one that's most likely to become damaged or ischemic if you have an insult. So if we've got events like tubular injury, like a strike, a fall, like somebody falls and lands on a railing or a bar, or you see this up at Snowball when like people are doing tricks in the park and they get on the rail and they fall and they either put their arm down and break their wrist, or they hit the rail, and they usually hit the rail on their side and on their back, right? And that could cause injury to the kidney. Or a severe blood disturbance, like the shock example that we talked about. So ischemia, right? Lack of blood flow. Patient isn't getting blood flow. We get tubular cell injury that takes place. That's within the nephron. It can either be reversible or irreversible. If we play this out, it leads to, in either direction, a reduced production of GFR. Over here, if you have ischemia, you cause vascular damage. If you have vascular damage, then you also reduce the activity of glomerular filtration. So either way you go, whether it's a tubular injury or whether it's the vascular tree, you're compromising urine production, otherwise known as oliguria. So acute tubular necrosis, most common. Shock. Etiological agents that cause acute renal failure with shock. So if trauma decreases blood flow, then you have a reduction in filtration and you decrease oliguria, urine production, and you don't make as much urine going from the kidney through the ureters, collecting in the bladder and out the urethra. Not as common, right? But definitely a reality. So what is shock? just to make sure we're level setting and everybody's understanding what we're talking about. B is in Bravo, severe reduced delivery of blood to tissues. Okay, absolutely. Loss of volumes, large volumes of blood, traumatic accidents, those types of things. Okay, so let's finish it up with infection. We're down at the post-renal components. We had pre-renal, we had parenchymal, and now we're post-renal. And I would say that of pre-renal, which is shock, parenchymal, like glomerulonephritis, and then post-renal, like the common understanding is probably more in the lines of post-renal, like urinary tract infections. But what people don't likely understand is, hey, these are pretty severe. They're pretty easy to treat, but if something goes untreated, the consequences are pretty big, right? But most people are familiar with these types of incidents. They've either had one, they know somebody that's had one, they've been working in the hospital, they know it's very common, especially patients that have long-term indwelling catheters, right? In our older population, they're very, very common. So urinary tract infections. So we either could have a descending infection or we could have an ascending infection. So a descending infection, what is that? Well, that means that there is a Staph aureus infection in the bloodstream or an E. coli infection in the bloodstream. And that bacteremia gets trapped and makes it into the kidney tissue because it's a filter. So it captures that bacteria that's been propagating throughout the bloodstream. That's a descending, or what we refer to as a hematogenous infection. Hematogenous meaning bloodborne. That makes sense? Not as common. So that's the hematogenous. The ascending infection, which is a little bit more familiar in what we've been talking about, where you've got E. coli or an enterobacteria. There's bacteria that's on our skin. There's bacteria, obviously, that is living in the GI tract. So after defecation, if that area isn't clean, or in kids, especially in young girls, kind of the way that they manage their bathroom procedure and how they wipe is a very important thing. Go front to back versus back to front. These little tiny things that are very important for pediatric care. It's not uncommon during labor for there to be, there's a lot of pushing that's happening. So defecation takes place. It gets a little messy. So there could be an infection post-labor. Women are obviously more, maybe not obvious, but women are more at risk of developing UTIs on an ascending infection than men. The proximity of the urethra to the anus, the length of the urethra versus male versus female anatomy. But these ascending infections will come up the urinary tract, can culture in the bladder, and the dangerous piece is if it goes through this vesiculorenal reflux and makes it retrograde and takes residence up into the kidney. And this ascending infection with this reflux leads to a condition known as pyelonephritis. This is an ascending urinary tract infection that has reached the kidney, that it's reached the pelvis of the kidney, as the terminology defines. The pylon is the pelvis in Greek of the kidney. So in an extreme case of pyelonephritis, you're going to have this reflex that takes place, a bacterial inflammation of the kidney, either the renal pelvis, the functional tissue of the kidney, the parenchymal tissue, or the renal calyces, and then some contributing factors of age groups that are more at risk. Women are higher risk factor than men. Individuals that have a history of urinary tract obstructions, Because if there's an obstruction, that means the flow isn't moving out as smoothly as it should, and so things can kind of pool. Um, diabetes. Diabetes discourages healthy filtration, and you get a lot of sugar in the urine. You get a lot of um, other outputs in the urine that, if they pool, now it's a breeding ground for bacteria to take place. There could be congenital abnormalities in certain patients where the flow is low out, allowing for pooling to take place. And then this VUR. So this is a reflux that takes place in certain individuals or certain patients where it's like an abnormal sort of regurgitation or retrograde activity that takes place where it travels backwards. A little bit of urine, because of the way that the muscles contract, the urine kind of moves upwards. And in everybody, there's a little bit of this, but in some patients, it's pretty aggressive. And so patients that have a more severe VUR reflux they're at higher risk of developing pyelonephritis or having a condition of pyelonephritis. So the aggressive form of pyelonephritis is reflex nephropathy. Reflux nephropathy. So this is where there's repeat kidney infections over and over and over again, associated with UTIs, like chronic UTIs that are untreated, and a VUR reflux that is more aggressive than quote unquote normal. And it induces scarring that takes place in the kidney and you lose functional tissue. So, true story. One of our kids, when they were young, like itty bitty, 2 years old, maybe 18 months, had a fever. My wife and I were supposed to go on out of town. And it's pretty common for kids to have fevers. So her fever was, 101. It's like, okay, well, get some Tylenol, and watch. Fever kept rising, and gave more Tylenol at the right time in communication with the pediatrician. Canceled our trip. Fever got up to like 103. We're like, okay, well, we don't want to leave the little one with grandma and grandpa and then leave town, and then we got to come back. Okay. So the fever wasn't breaking, and we're doing the Tylenol thing, and so we decided to take her into the pediatrician. Pediatrician did a rectal thermometer and measured 107, and we're like, whoa. And we were just doing like, kind of one of the digital ones that goes under the tongue, or we go, from the armpit, but rectal temp was 107. They admitted her to the ER, went into, pediatric ICU, and they did a blood test, a urine test, and she had an infection. There was bacteria in the urine, urinary tract infection. Well, they did a scan and discovered that she had a kidney infection. It had made it all the way up to the kidneys. So, we were glad we didn't go. No issues. Prescribed antibiotics, but it was actually super scary. This is like modern day Western world. It's not like we were neglecting our kids. It's just one of the, they get sick. Stuff happens, right? So this is a real thing, right? This is a real thing in patients. Now you take that to patients that are in a nursing home and they're older and they're bedridden and they're using a bedpan or they have a catheter in. Like, this happens a lot. Okay, now, pediatric kidney infections versus geriatric. Geriatric patients aren't going to need those kidneys as long as the pediatric patient, but still, the severity is still there. Okay, so it's kind of it seems like kind of something that we blow off in medicine, but it has pretty severe ramifications. Okay, any questions over what we covered today? All right, great. I'm going to pause.